Introduction. There are several people on Zoom and other people are coming. So, hey, thank you everybody for coming. It's an honor and privilege to introduce our speaker, grand round speaker today, Dr. Mark Alberts, a nationally renowned neurologist in the field of neurology in general and stroke in specific. He got his degree from Tufts. He got his residency and fellowship training in stroke from Duke. He has lived a very active academic life. Time will not allow me to mention everything, but more than 200 publications, very active role with the American Academy of Neurology and other institutions, leading courses, teaching other physicians, reviewing grants and different committees around the nation. He has assumed several leadership positions in his careers. The one that I want to mention the most is the vice chair at the medical director at UT Southwestern in Dallas from 2012 to 2017 before he moves back to Connecticut. And as you can see, he's currently a professor with the University of Connecticut, chief of neurology at Hartford Hospital, and co-physician-in-chief at the IR, I hope I'm pronouncing it right, Neuroscience Institution. So without further ado, please join me in welcoming Dr. Alberts to our talk today.
Thank you. Thank you very much, Dr. Saab, for that very kind introduction, and welcome to Grand Rounds. So we have a few people in the room, and I know we have dozens, if not hundreds, on Zoom. So I hope you are all seeing this and enjoying this. I'm going to focus on a very challenging condition, which is basilar artery occlusion. I know this is a mixed audience. I suspect the neurologists know what this is all about. And for those of you who are not neurologists, I will just say that this is not the most common, but it is among the most deadly types of ischemic stroke one can have. So we're going to talk a lot about that in the next 45 minutes or so. These are my disclosures. This is the outline and objectives. We're going to review the anatomy, symptoms, and natural history of basilar artery occlusion, discuss different approaches and options for patients with this in terms of treatments, and explain the different outcome measures used in clinical trials of basilar artery occlusion. So let's start with some basic facts in anatomy. This is a picture of the bottom of the brain here. You can see the basilar artery in sort of that lavender color right there. So the vertebral basilar territory receives only about 20% of systemic blood flow, and it accounts for about 20% of strokes, so that makes sense. Yet only 1% of strokes are due to basilar artery occlusion. And why is this the case? Well, this is where some basic anatomy comes in handy. In most patients, the basilar artery is about only 3 to 4 millimeters in diameter, so it's really quite small. It gives rise to a number of median, paramedian, and circumferential vessels or perforators that come off here. And it's actually, many of them are too small to see in this photomicrograph. And it has a male to female ratio of about 2 to 1. But there are some important size considerations here. Okay, usually the left vertebral artery is slightly larger than the right. The average size of the vertebral artery is about 3 to 4 millimeters, and the size of the basilar artery can vary, but in many cases, the basilar is smaller than the vert is. In many cases, the vert may be a little bit larger, but this is why it's important, because if you have a cardiac or systemic embolism, for it to occlude the basilar artery, it would have to be small enough to get through the vertebral artery. Right? So, i.e. a 5 millimeter clot in the basilar could not get through a 3 millimeter vertebral artery. That's why if there's a big clot in the basilar artery, chances are it didn't come from the vert or the heart, it had to form in situ because of this size differentiation. So this provides important clues about the possible etiology. So because of this size differential, the basilar may sometimes be partially protected from some of these embolic events if the clot cannot get through what may be a smaller vertebral artery. And this is in some ways good because the basilar supplies a lot of very valuable real estate in the brain in terms of the pons in the midbrain. And if you occlude blood flow here, you're going to end up with a devastating clinical deficit. So these are the regions supplied by the basilar artery. You have the pons, the midbrain, the cerebellum, and the thalamus. And the structures involved from a neuroanatomic and neurofunctional point of view are key structures in the brain. This includes the descending motor tracts, the ascending sensory tracts, the reticular activating system, which is responsible for our awakeness, alertness, consciousness, multiple cranial nerves, 3, 4, 5, 6, 7, 8, and then parts of the cerebellar hemisphere and the superior cerebellar peduncles. So from a neurologic point of view, this is extremely valuable real estate. It really controls everything that we do, with the exception of some parts of speech, vision, and cognition. So what are some of the signs and symptoms of a basilar artery occlusion? Some of the most common are motor symptoms, especially bilateral weakness of the arms or legs, typically bilateral, but it could be quadriparesis. Alterations in consciousness, including lethargy, obtundation, coma, and even the so-called locked-in syndrome, where you may be somewhat awake and alert, but you can't move or talk. Various cranial nerves, especially those affecting the eyes, face, dysphagia, swallowing, and dysarthria. Involvement of bilateral tracts and cranial nerves can produce a bulbar or pseudobulbar syndrome, Horner syndrome, dizziness, vertigo, emotional incontinence, and then various cerebellar abnormalities, dysmetria, ataxia, tremor. Oftentimes these are bilateral. Now, the patterns of onset, unlike hemispheric strokes, they can be sudden, but they oftentimes can progress with progressive motor symptoms combined with loss of consciousness. It's not uncommon to have a stuttering pattern over several hours or days, unlike hemispheric strokes, which tend to come on and be maximal at onset. Basilar artery strokes may have a more stuttering or gradual course. And there may be prodromal symptoms, such as headache, changes in vision, paresthesias, dizziness, vertigo. And these may last a few minutes, and they may come and go before they become permanent. So these are some of the clues or telltale signs that you may be dealing with a basilar artery occlusion. May start off partial and then become more complete. So these are some signs that you all should be able to recognize. Number one is what's called a hyperdense basilar sign. And it's this white dot right here in the prepontine cistern. And it's this white dot right here, right in front of the pons. Now, sometimes this white dot is just a calcified artery, or it could be a calcified embolism that may not have any functional significance. But this, in the proper clinical setting, with the signs and symptoms I was just talking about, needs to raise your index of suspicion that this could be a basilar artery thrombus or basilar artery occlusion until proven otherwise. And here you see a hypodensity in the cerebellum. So you see this, which is a partial ischemic stroke with a hyperdense sign in the basilar thrombus until proven otherwise. So this is just on a plain head CT scan. Remember that. This is a CTA of a basilar artery occlusion. And what I say here is you have to know what you're not seeing. So you have to know what a normal CTA should look like to know when you're seeing something abnormal. And this is very subtle, but you see that gap right there? That should be filled with contrast. That should be the basilar artery coming up here and then coming up at you. So it should be white, but you're not seeing it. Like I said, you have to know what you're not seeing. Telltale sign of a basilar artery occlusion. Here's another view of a CTA. This is part of the basilar coming up here. And then you see this gap because the top of the basilar is occluded. So you have to know what you're saying, but you have to know what you're not seeing. Another picture, basilar artery occlusion, CTA. This is a case of a mid to superior basilar. It's absent. This is the proximal basilar. You can see part of a vert here, part of a vert here. Proximal basilar is open, but mid to distal basilar, nothing there. Again, this is a distal basilar occlusion. This is part of the PCAs that may be supplied from the anterior circulation in some cases. So again, you have to know what you're not seeing. What are some of the etiologies for basilar artery occlusion? The most common, atherothrombosis, a plaque, or an embolism. Could be a local embolism, artery to artery embolism, or systemic, like from the heart, from AFib, hypercoagulable state, things like that are uncommon. But again, you have to know when to diagnose these. Dissection of a vert, or you can have dissection of the basilar with head trauma. Tumors, sickle cell disease, vasculitis, congenital small basilar, and again, the hypercoagulable state, oftentimes due to underlying cancer, hematologic conditions, or genetic factors. So in common is athero and embolism. These are uncommon. So now let's talk about treatment and outcomes. And there were several registries here that I'm going to talk about. This was published in the Journal of Stroke and Cerebrovascular Disease in November of 2020. It's a Japanese study. Japanese folks have a lot of intracranial athero disease, more than Caucasian folks do. So this is a great population to look at something like basilar artery occlusion. And this was their study, a fairly large study for basilar artery disease, started with almost 200 patients. This was a prospective but not randomized study. With these folks, they divided them up into mild or severe, as judged by the NIH stroke scale score. Score of less than 10, they called mild. 10 or greater, they called severe. And again, this is endovascular therapy, which is a mechanical thrombectomy or standard medical therapy. You can see in the mild group, about 20 and 20. In the severe group, over 100 got endovascular therapy. Only 22 got standard medical therapy. So again, a fairly large study. And they broke out the outcomes by whether they had mild symptoms at entry or baseline and severe symptoms. And again, this is what we use to divide it up in terms of the different NIH scores. And this is the modified Rankin. We use this to judge outcomes. Basically, a modified Rankin of 0 means that you're normal, 1, minimal symptoms, 2, some disability, but usually you can take care of yourself. Once you get 3 or more, it means you have trouble with walking and taking care of activities of daily living, can't walk or drive or go to work, things like that. So the darker the color, the worse the outcome, if you want sort of a global perspective. And you can see if you have mild symptoms, you tend to have better outcomes, whether you get endovascular or standard medical therapy. Although even in the small study, you can see there was a trend for folks who got endovascular therapy to do better. In the severe group, you can see there's a lot of dark colors here. So folks with severe symptoms, no matter how they got treated, tended not to do very well because, again, a lot of dark colors here. There was a little trend for better outcomes with endovascular therapy, but again, this was a non-randomized study. So this is, again, breaking down outcome by MRS and stroke severity. The mild group is in white. The severe group at baseline is in red. And you can see the mild group just tended to do better, no matter what treatment they got, endovascular or standard medical therapy. The severe group at baseline, as shown in red, again, looking at scores of 0 to 3 or 0 to 2, tended to do less well. Although, again, the folks that got endovascular therapy overall had better outcomes than the folks that got standard medical therapy. And these differences were statistically significant, but again, not a randomized trial. Safety outcomes, there were no real safety concerns in terms of intracerebral hemorrhage. So the conclusion from this study was that patients with basilar artery occlusion and mild symptoms tended to have better outcomes. Overall, endovascular therapy appears to improve outcomes and to be relatively safe, but again, small study, non-randomized. Now, there's a larger study recently published called the Swedish Registry, and they looked at endovascular therapy in folks with basilar artery occlusion in Sweden, nationwide prospective registry study. The advantage of some of the countries, Scandinavian countries like Sweden, Finland, and the like, is that almost by law, they shunt all of their patients to the one or two major medical centers, the academic centers. So as nations, they tend to have bigger numbers, better case ascertainment, and to some extent more standardized therapy because they're only being treated in like 1 or 2 or 3 hospitals. So that's why we like some of the Scandinavian studies. So again, they looked at different treatment strategies and lesion location, proximal basilar artery occlusion, mid or distal. Again, a few dozen patients in the study. If you add this up vertically, you can see what they were. And they looked at aspiration alone, stent retriever, angioplasty stenting, and then they looked at the degree of vascularization. And they defined vascularization. We, as neurovascular people, look at what's called the TICI score, and a score of 2B or 3 means that there's almost total or very close to total revascularization of the basilar and the important distal branches. So in terms of successful recanalization, as you can see, if they had a proximal occlusion, it was 75%, mid 84%, and then distal 87%. All in all, about 83%. So they did a good job in this study getting high rates of revascularization or recanalization using a bunch of different strategies here. Just aspiration, stenting alone, things like that. So again, this was very much of an interventional study. Relatively few patients, at least in this registry, got standard medical therapy. So a little bit biased towards mechanical thrombectomy. Then they looked at 90-day survival rates. And again, if they had a proximal occlusion, as shown here, and I guess that's blue, partially colorblind here, so bear with me. But the blue folks had the worst overall survival. The distal, up here, I think in green, had the better. And the mid, here in whatever color that is, pink maybe, in the middle. So again, this goes along with a general theme that based on where the location is, proximal occlusions tended to do poorly, distal tended to do best, and the ones in the middle were in the middle. So stroke severity at baseline makes a difference, and the location of the inclusion makes a big difference. So now they looked at functional outcomes by lesion location. And again, distal, mid, proximal, looking at all of them. Again, this is the modified Rankin. So black means that you're basically dead. The darker the color, the worse the outcome. The lighter the color, the better the outcome. So these folks here in the white stippled had pretty good outcomes. And you can see if you look at all of them, only about 30% of them had a good outcome with a modified Rankin of 0, 1, or 2. Bunch here, 17, 20 some odd percent had medium outcomes. And then again, in the dark colors, 34%, 32, 51, 38, 39% had really bad outcomes, i.e. they were dead. So again, that's why we say basilar artery occlusions are among the worst types of strokes to have, with very high rates of death and disability, as shown here. If you add up these darker numbers, you're ending up with rates of death and very bad disability of 40, 50, even 60% in some of these patients, which is really bad. So there was another registry study published in Lancet a few years ago, and this is called the BASIC study, Prospective Registry Study. And again, keep in mind, 2009 was before we were doing thrombectomy. Now we do thrombectomy all the time for M1 occlusions, some basilars and things like that. But back in 2009, they were few and far between, which is why they did so many of these registry studies. So this was a prospective design. They looked at patients from 47 comprehensive stroke centers. So this is one of the largest studies ever published. They looked at folks with basilar artery occlusion, proven by some imaging modality, and appropriate symptoms. They didn't treat a whole lot of asymptomatic people. Some of them did get IV TPA. Some of them got IA lytics, and some of them got mechanical thrombectomy. They were all enrolled within 24 hours of symptom onset. About a quarter of them were treated more than 9 hours after symptom onset. Again, back in 2009, that was very unusual. Now we treat patients up to 24 hours, but again, treating them beyond 9 hours was thought a little bit pushing the envelope back when this was studied. In one of the largest, they define a good outcome as a modified ranking of 0 to 3, and is one of the first times that this definition of a good outcome was used in our medical literature. Now for thrombectomy, we commonly say a good outcome is a modified ranking of 0 to 2. But again, this sort of began a trend of a little bit moving the goalposts, and we'll talk more about this in a minute. So overall, there were no major differences in outcomes according to this subgroup analysis. For all of them, age, baseline score, occlusion site, all of these favor endovascular therapy compared to whatever the control was. So again, this was one of the largest studies to give us an inkling that endovascular therapy may be effective in this very challenging population of stroke patients. And again, all of these subgroups seem to benefit. What about age and treatment? Looking at all patients, age less than 50 years of age, about 20% of patients. Age greater than 70, about 37% of patients. The rest of them had ages in between, and this is looking at how they got treated. And AT is antithrombotic therapy. A lot of them just got that. Some of them got IV TPA, for example, and then some of them got intra-arterial thrombolytic therapy. So again, very much of a mixed bag because this was not a prospective randomized trial. They sort of got whatever they wanted to get, and they sort of had modest numbers overall. What about time to treatment and baseline deficit? As you can see here, about a quarter of them were treated late, but a fair number, about a third were treated 0 to 3, another third treated 3 to 6 hours. So again, this sort of emphasized early treatment, but of course the patients need to come in early for them to get treated early. And a lot of folks with basilar artery occlusion don't come in early because of mild symptoms or fluctuating symptoms, things like that. But I thought this was a pretty good study. And again, if you look at the numbers, we're talking about hundreds of patients treated, not randomized, but at least collected in this large registry. So this had the advantage of good numbers, but it was not in any way randomized. But look here, almost 60% of patients had severe deficits. So you would expect that their outcomes would not be that good. So again, if you look at the clinical outcomes, here the color scheme is a little bit deficit, but the dark blues are the worst and the lighter colors are better. So overall, you can see mild to severe, the mild to moderate deficits did better. Severe deficits did worse. And again, this is based on antithrombotic therapy, intravenous lytics, intra-arterial therapy. If you have a mild deficit, you just tend to do better no matter how you're treated. If you have a severe deficit, tend to do worse no matter how you're treated. A lot of blues and reds here, which means that these folks really had bad deficits, and at the end of the day, they did not get much better. So now we're moving into some of the more modern treatments. This was a JAMA article, JAMA Neurology, published just a couple years ago, 2020. Assessment of endovascular treatment for basilar artery occlusion. This was a nationwide prospective registry, and the group was called the Basilar Group. One of the largest registry studies, 1,254 patients. Vast majority got treated with endovascular therapy versus SMT, that standard medical therapy. Could have been aspirin, IV heparin, something like that. let's see. So if you look at the occlusion sites here, you can see this is all patients. The occlusion sites were sort of equally distributed. For the controls, again, a lot of the control folks had middle basilar artery occlusions. And in terms of the folks that got endovascular therapy, fairly wide distribution of where the occlusions were. Again, most patients had mid to distal lesions. Most were treated with a combination of devices, and then most were treated within 6 hours of symptom onset, as you can see here. So if you look at the primary efficacy outcomes, they looked at the modified Rankin at 90 days, which is standard, and then they looked at different outcomes, as I alluded to a few minutes ago. 0 to 3 means that you have some deficits. 0 to 2, functionally, you're able to do okay. 0 to 1 means that you have very few symptoms, but functionally, you're able to do everything okay. So if you set the bar that you want to be normal, very few people are able to achieve that. 17% for everybody. For endovascular therapy, about 20%. If you have a modified Rankin of 0 to 2, which we use for like thrombotic therapy, endovascular therapy, for an MCA stroke, here you can see all patients, about 23% achieve this, so not that good. Endovascular therapy, 27% achieve this. But if you move the goalposts a little bit to a modified Rankin of 0 to 3, well, here the numbers look better. All patients, 27%, and the endovascular patients go up to 32%. So you can increase good outcomes from a quarter to a third by moving the goalposts, which I think is, well, I know what I think. The question is, what do you all think of that? It is a way of showing better efficacy. It is a way of saying, well, these patients have bad deficits when they came in. Maybe this is a way of treating them. And frankly, what other options do we have? Aspirin or heparin? We know those things do not work very well. The other gratifying thing is that if you look at TICI scores in this group of patients, you can see that overall the TICI scores, 64% had really good recanalization. And just for the endovascular group, that went up to 81%. So the therapy works, at least from an anatomic point of view, and it has some benefit from a functional or clinical point of view. But you're not seeing huge numbers like a 50 or 60% having great clinical outcomes, as depicted here. There were really no major safety concerns per se. In terms of symptomatic bleeds, now we're just talking about intracranial hemorrhage. 7% of people with endovascular therapy had symptomatic bleeds. 3% had asymptomatic bleeds. But I hasten to add, and this is oftentimes overlooked when the data are presented in this way, these symptomatic folks, the 7%, and again, big numbers here, over 600 patients, are included in these outcomes, right? So you don't take these outcomes or these differences and then subtract 7% because of the bleeds. The folks with the bleeds are included in these overall global outcomes. And now they did propensity matching to correct for baseline imbalances in terms of age, gender, hypertension, diabetes, things like that. And even using the propensity matching, again, these dark grays are bad outcomes. The control folks had a lot of people with bad outcomes. These were reduced for the folks who got endovascular therapy. And it's about the same whether you use the propensity matching statistical analysis or the overall. Again, the endovascular folks did better with therapy, but again, not great as would have been depicted with these colors. You can just look at it with your eyes and just see that very few folks had really great clinical outcomes because this is a really bad disease. And doing a subgroup analysis, basically all the subgroups appeared to do the same in terms of they all seemed to benefit, but the degree of benefit, let's be honest, was modest here. So now we move into the new studies. This study was published in New England Journal in May of 2021, so a very recent study. This is one of the largest studies to look at endovascular therapy for acute stroke due to basilar artery occlusion. So we're going to go over this in a little bit more detail because it's one of those pivotal studies. They had to be treated within 6 hours. So this is very early treatment. Age less than 85. So they're sort of, mixing things here or selecting patients who may have a better outcome. Eligibility for IV TPA, but due to slow enrollment, they changed this so that there was no age limit and no TPA eligibility was required. So initially, folks had to be eligible to get TPA, and then they said, well, we're getting so few patients, let's forget about TPA and just look at endovascular therapy. This was a prospective randomized trial, but it was open label, but with blinded outcomes. These are the baseline characteristics. So about 300 patients were enrolled and randomized. No real differences with age, gender, things like that. Mean NIH score was 22. So these were pretty sick patients at baseline, pretty sick. And time to enrollment was about 4 hours because they had to be eligible for TPA. So let's look at, let's see, I think this builds. Yeah, let's look at some of the primary and key outcomes. So their definition of a good outcome was a modified Rankin of 0 to 3. Which again, not quite as good as 0 to 2, which is what we use for a lot of our studies, but 0 to 3. And here they found 44% with endovascular therapy, about 38% with medical therapy. So an absolute difference of only about 6%. Again, not particularly overwhelming. And this difference was not statistically significant. Again, a trend for better outcomes with endovascular therapy, but not that dramatic. And again, you can see as you move the bar here of a good outcome of 1 or modified Rankin of 0 to 2, which is what we use in most endovascular studies. Here, the outcome differences are only 5%, not close to being statistically significant. But again, this was just one study. And you can see how moving the definition of a good outcome of 0 to 1, 0 to 2 to 0 to 3 really changes the fidelity of the study. And if it had been 0 to 2, which is what we use in a lot of studies today, would not have been close. Intracranial hemorrhage, we talked about this, about 4.5 or 5% with the endovascular group, but these outcomes are included in these outcomes. And you can just visually inspect this and be unimpressed by the difference between this and this with medical care versus endovascular. Just not that impressive, not a whole lot of bang for the buck. And again, the subgroup analysis shows this because you can see a lot of these lines here cross 1, they cross unity, which means that the differences are not statistically significant. So conclusions, and at least this study, patients with BAO treated with endovascular therapy did not show a significant benefit in terms of outcomes. They did have higher rates of bleedings, but again, this did not preclude other studies showing other outcomes. And this is one of the other studies. Published in New England Journal, actually just less than a year ago. This is the attention study done in an Asian population for the most part. Endovascular treatment, acute basilar artery occlusion. 12-hour treatment window. So the last study was 6, this is 12. 2-to-1 allocation. Some of them, a third of them were treated also with IV TPA, but they had to come in soon enough. Here again, they used a modified Rankin of 0 to 3 as the definition of a good outcome. Safety outcomes were assessed to 24 and 72 hours, as well as 90-day mortality. This was the study design. Again, a modest size, a little bit more than 300 patients, which is reasonable. Typical location of the basilar artery occlusion. As you can see here, about a third were proximal, about a quarter were mid, and a third were distal. Reasonable allocation. And again, about a quarter to a third did get some type of IV lytic therapy. So primary outcome, modified Rankin of 0 to 3 at 90 days, 46% versus 23%. So really a 2 to 1, 2 times odds ratio for the endovascular group to have a better outcome than a medical therapy group. And this was statistically significant. If you look at other outcomes, depending on how you parse it, they all look statistically significant in favor of thrombectomy. Again, this is a 12-hour study, not the 6-hour study. Again, the intracranial hemorrhage, more with thrombectomy, 14% versus 2%. But as I've said before, these bad outcomes are also included here. And here, your visual chart inspection can show that at least for the really bad outcomes, death and disability, much higher, 55% versus 37%. If you look at what I consider a good outcome, modified Rankin of 0 to 2, here there is benefit, 33% with thrombectomy, 11% in control. So this is really good news with a 12-hour window for thrombectomy for the worst type of ischemic stroke that we have. Subgroup analysis now is showing some trends for benefit with endovascular therapy in all of these different subgroups. Age, time window, location of occlusion, baseline aspect score, things like that. And now another study, the BAO-SCH group, don't know what the basilar artery occlusion group, published in New England Journal less than a year ago. Again, a lot of investigators were from Asia. Age 18 to 80, basilar artery occlusion, or both vertebrals, randomized 1-to-1 endovascular therapy or standard medical therapy. The initial endpoint was 0 to 4, again, moving those goalposts. Then they changed it to 0 to 3 near the end of the study. Between 14 and 21% were treated with IV TPA. This is the standard patient population. Again, about a little bit more than 200 patients were randomized. So modified Rankin of 0 to 3 at 90 days. In the thrombectomy group, about 46% versus all 24% in the control group. So almost 2 to 1 in favor of thrombectomy. If you look at modified Rankin of 0 to 2, here it's 39% versus 14%. Again, clear benefit with the odds ratio of approaching 3 in favor of thrombectomy versus control. A dramatic improvement, 25% versus 10%. So again, these again is showing some benefit for thrombectomy versus control therapy. And safety outcomes were about the same as what we just talked about. So again, this is looking at patients treated up to 24 hours after symptom onset. So this was one of the real pivotal studies that changed our minds about when and how we should be treating these patients. That's why it was published in New England Journal of Medicine. Again, the few bleeds are accounted for in the overall outcomes, and the benefit in these various subgroup analysis is actually very heartening. It's very positive. So conclusions are that endovascular therapy up to 24 hours was associated with improved 90-day outcomes. They did have higher complication rates, but again, these are counted. The absolute benefit of 22 to 24% at 3 months, even including these complications, is impressive. But we do need to keep in mind that a 6% rate of ICH is still somewhat worrisome. So let me give you the overall conclusions and leave a couple minutes for questions. Patients with basilar artery occlusion have a range of potential outcomes. However, this, with modern therapy, is no longer a universally devastating condition. The folks with the proximal lesions do tend to have the worst outcomes, no matter how they're treated. But for endovascular therapy to be effective, the patients need to be carefully selected, and the endovascular team needs to be skilled and experienced in doing this, because you're messing around in the basilar artery. If you rupture that or cause a bleed, it's going to be devastating outcomes. In advanced imaging, I'm hopeful that as we go forward, advanced imaging may be useful for selecting appropriate patients for endovascular therapy. That's it. Thank you for attending in person and via Zoom. And I'm happy to answer any questions or field any comments that you may have. And again, thank you for the gracious invitation to be here at Erlanger and present Grand Rounds. Thank you very much. Yes, sir.
Any idea why the proximal occlusion may be more difficult to treat than the distal one?
That's a great question. The question was, why are proximal lesions harder to treat? The answer is, I'm not sure. My gut feeling is that I think those proximal clots are larger, and I think more of them may be from cardiac events like AFib, make it through the vert, and then they get plugged up in the basilar. So that's just my thought, that the clots may be harder, bigger, and maybe have a different origin, maybe more difficult to mechanically remove. The other thing is that it may just be mechanical because they have to get there somehow, like through a vertebral artery. And it may be that just they can't get all of the stents and stuff that they need to get up there to grab some of these, especially if the clots are in situ. Right, if the clot forms in a proximal basilar, if there's a big plaque there, which is where a lot of the plaques are in the proximal basilar, so you have clot and calcified stuff, and you just can't get it out. Trying to do endovascular therapy on a atherosclerotic plaque, it's like trying to remove a brick with a corkscrew. Just doesn't go very well. So it's a great question, and I think there may be a number of factors. Yes. Hi.
And I know that you had mentioned that a lot of the studies sort of change the goalposts in terms of good outcome from MRS, whether it's 0 to 2 or 0 to 3 or 0 to 4. Is there any sort of rationale that has been utilized like across the board for why change that?
Good question. The question was the various studies that have different goalposts or good outcomes, like for endovascular care, we commonly say 0 to 2, but for basilar, they started 0 to 3 and then 0 to 4. I think there's two reasons. Number one, everybody likes positive studies, and by moving the outcomes, you have a positive study. That's the cynicism in me. The practical aspects in me, the care aspects in me, the giving aspects, are that these folks have bad strokes. So when you're locked in, is it reasonable to expect an outcome of 0 to 2 when you're starting with such a severe deficit? Is it more realistic to expect an outcome of 0 to 3? So you don't want to throw the baby out with the bathwater. You don't want to say it's a negative study when you're starting with such a bad deficit. So I'm giving you the gracious aspect, and I'm giving you the hard aspect. And I think both of them play a role in how you design and look at the study. Is the glass half full or is it half empty?
I guess as a follow-up, it just seems like if you stretch it to be a good outcome is 0 to 4, you might actually have overlapping groups when it comes to control as well as intervention. You might have a lot of people that kind of end up in the middle. Yeah.
The question was, if you define a good outcome, as I did in one of the studies initially of 0 to 4, then you're going to have good outcomes, more good outcomes in the control group, because it's the natural history. And I agree with you 100%. That's why you do prospective randomized studies that are propensity matched and that hopefully correct for some of these baseline imbalances. But I think with these two recent studies in New England Journal showing benefit, I think this has really moved at least the treatment goalposts to give our endovascular folks reason to believe that in this very challenging group of patients, and let's be honest, what are the alternatives? Aspirin, IV heparin, a nursing home, rehab. I think we need to be very thoughtful in terms of who we select for this and who we don't. And just when we have a conversation with patients, and I think these studies, these diseases are a good case in what's called shared decision-making. I think the neurologist, neurosurgeon, endovascular person, and the patient's family need to all sit around the table and understand the risk versus benefits and the meaning of the alternative treatments, if there are any. But thank you, those are all great questions. Can they ask questions over Zoom or? If there's any Zoom questions? Yeah. I don't see I don't see any chat thing if.
I'm following. No questions.
No questions, okay.
One last question.
Yeah.
I'm sorry. So you mentioned carefully select the patient for the intervention. And you mentioned maybe imaging will help us in the future. Any insight of this? I mean, are we going to have some similar perfusion studies? What do you think?
Yeah. So that's a great question, and that's exactly the point I was getting at. As you all know, when it comes to an M1 occlusion, we do the CT rapid studies looking for a perfusion-diffusion mismatch and everything like that. It would be great if we had the resolution to be able to do that at the brainstem level. I think we can somewhat do it for the cerebellar hemispheres and maybe the PCAs, the occipital lobes. So it would be great to have a package that combined all that. So far, I haven't seen the resolution being that good, but I promise you there are people working on that. And I think that would be a case where combining where the quad is and what the perfusion looks like and what the amount of salvageable brain looks like could really be beneficial. So stay tuned. Maybe next year at the stroke meeting, they'll announce that.
Thank you so much. Thanks again.
Thank you all for attending. Appreciate it.